Good morning. Happy Thursday. I have Neuro Coffee in hand and it is perfect. Zach Fender, great shirt.
Thank you.
You're not required to wear that on these calls. You know that, right?
I know it was just laying on the ground actually next to me.
Fine. Now I feel so much better. It was laying on the ground.
Well, it was folded. I just didn't get to put it away.
I found it in the trash and I thought I'd wear it today.
No, it was folded and clean. It just did not make it back into the drawer. All right. So I have a question. Like just trying to refine the process that got me to an outcome a little bit. So I've only seen this patient once, but they're coming to me for low back pain. Pretty much like anything where she had to assume like a flexed posture. So toe touch was the main KPI that we were using. But
it was painful. It was painful or just
painful. Yeah, like 5 out of 10 pain. Kind of like both sides.
I'm sorry. Just pain scales are one of my pet peeves.
No, all right.
It's all right.
I don't know if that was a pet peeve of yours.
It is.
Okay.
Yeah. Because it's like it's usually a yes or a no, right?
Yeah. All right. A good amount of pain bending over. Or just like anything where it was like a flex posture, like sitting. She's a swimmer, so swimming's actually fine, but if she has to do her flip turn, she'll feel it.
Okay, that makes sense.
As far as a chessboard, like maxing out ER orientation with no IRs. So like 0 degrees of IRs in both hips, but like 50 or 60 degrees of ER. So my initial thought where I went first, which was unsuccessful, was like I just kind of did some manual, like basically put her in side lying and just like laid on her pelvis and rib cage to try to reduce the ER orientation, which did not do much. So then I kind of decided, okay, to maybe go after the anterior orientation instead. So with a little bit of manual work, and then I gave her like a hook line that pretty much got most of her pain away.
What did you do? I'm sorry, what did you do in hook line?
Just like hook line with a ball between the knees and just like try to get like a little bit more of a delay.
I got you. I'm with you.
Just static breathing. So that pretty much like pain was pretty much completely gone at that point. She was almost touching the floor.
Sweet.
So I was just like, I guess initially a little confused why that worked, because I felt like I would need to get the IR for the toe touch, but then I guess I needed the ER first. So now like trying to refine the thought process of like, was it just the fact that she was so far forward that I needed to bring her back first before she had a room, versus like if I see someone else with like a similar pain complaint with like a similar motion, but they're not as like they haven't lost as much IR, aren't as far forward, then maybe that's somewhere that I don't need to get the ER first. Does that question make sense?
Okay, so where was before you did the intervention, before you did the hook line, where was her ER?
Her ER was through the lumbar spine.
I'm sorry, space. ER space.
Out to the side.
Yeah. So it's way far away from midline, right? Because clearly she was pushed forward, right? Limited straight leg raise.
Yeah.
Okay. But was she touching her toes?
Initially?
Even though it was painful, was she still touching her toes?
No, she probably like fingertips to like just past her kneecaps.
Ah, okay.
Like very, very limited.
Okay. All right. So when you did the hook line activity, you had her feet like really, really far apart on the table.
Nothing crazy, but definitely like further from midline.
Okay. But I mean, like, see where my hands, they disappear from the screen. They were way out there where her space was.
Yeah.
So you put her feet that far apart.
Not
like a beach ball. You put a beach ball between her knees and you put her feet way out here.
Not that extreme, but further than like they were not shoulder width.
Okay. But point being is, it's like you actually brought her into some place where she could lay down some IR, right?
Mhm.
Okay. So what representation did you achieve relative to the starting conditions?
More internally rotated.
Which would be what? So you superimposed internal rotation on external rotation. So where did you bring her from? And then you brought her to?
Early to middle.
Well, you brought her to early.
Okay.
Right? Kind of makes sense.
Mhm.
Right? Because all you had to do was downregulate some of the motor output that she was cranking up, right? Because she's all ERs, right?
Mhm.
Which she's a swimmer, right? So that's not a big shocker. Okay. No, so you basically just reverse engineered the process. She was in an ER representation. That was good because it's very easy to move somebody from a late representation to an early representation because the difference is just going to be motor output. Then you get the connective tissue behaviors that are associated with early, which you went from overcoming connective tissues to yielding, right? Which would be the goal.
Yeah, I guess with the toe touch,
Mhm.
does that go like as you're able to descend further into it, does that follow like a similar arc as like what you talk about with a squat where like there is like an
I
early
wouldn't even talk about an arc in, man. Shame on you.
this arc was the wrong word, like
Arc is the wrong word.
follow a similar pattern of having like an early, middle, and late representation or
Okay.
ER.
Okay. So here would be my trick question. Okay.
It's too early for trick questions.
Is a toe touch a bottom up activity or top down activity?
Is a toe touch bottom up or top down? I would say
Hey, here you go. Are you ready? Are you ready?
maybe.
You're 12 months old. Okay. You're 12 months old.
Okay.
And you're gonna do it. You're gonna touch your toes. Okay. And then return to stand. How are you gonna do it?
I'm not sure what you're asking by that.
So you're crawling across the floor on your hands and knees. You push back into your feet. You sit down into a deep squat. You touch your toes, and then you stand up.
Bottom up.
There you go. Okay. So when you're looking at a toe touch representation, because we're all grown-ups and stuff, we tend to start these things from the top down, even though they're bottom up activities. So the representation is that you're in a late representation at the top. You have to pass through middle on the way down, and you're going to be in an early representation at the bottom. Okay. You follow?
Mhm.
Yeah. So she walked in, and again, it's like, she had a lot of ER represented, not a lot of IR, because the IR, like the way she was putting IR into the ground was way far away from midline. Okay. And what you did is you gave her the capacity to delay the current representation that she was in. She went from late to early. She superimposed some IR. So you gave her the end of the toe touch. Because you gave her some IR to use, she was able to access some representation of middle. So the toe touch gets better, pain gets better.
All right.
So you gave her the delay, and then you gave her an opportunity to change shape. And now we're kind of back to Dante's question a little bit, right? Because all she did, she couldn't change shape. Therefore, she couldn't move into those spaces. You follow?
Yeah.
Yeah. Yeah. Good morning. I have Neuro Coffee in hand, and it is perfect. Robbie, is that a question squared?
That is ×2.
Okay.
All right. So first and foremost, I was on the call back in August.
Oh man.
Asked you
Was
a couple
I live then?
and I can say it was one of the best things for my golf coaching. So
Okay.
So I have a couple questions. So I'll start with this one. So you talk about both iliums being in an ER representation in the backswing.
Yes, sir.
Now, like the backswing starts before the club starts moving back. So we need some sort of like a trigger or something to get
Yes,
the
absolutely.
the slosh.
The slosh. That's a great way to look at it. That's a great way. Absolutely.
So for that sloshing, how would you recommend? Is that like a plyo step kind of idea where you're like creating some eccentric orientation in the lower posterior outlet kind of deal? Or
so I love that thought, but if you say plyo step to somebody and there's no step and the movement is really, really small, that you can almost not see it, right? But you're absolutely right. You're absolutely right. What you got to do, so think about this for a second. The guts have to drop, right? So because you're in sort of this like middle-y kind of a representation in a dress. And then there's technically no differential. There's a little bit of differential just because of the grip of the club and such like that. But if you think about it's like when I bring the club back to impact, it's like that's going to be a really, really strong middle representation. So you got to drop the guts because I got to create a differential, right?
yes.
Yeah. So you're absolutely right. And what you'll notice is, and you might hear it, is that you'll hear the.
Interesting.
You know what I'm talking about? Like when they first take the club away.
Oh, okay.
Listen to them breathe. There's a breath hold and a release as they break the club away from the ball. Okay. Think about it. You're a golfer.
Yes.
Take your address. Okay. Do your waggle. Everybody's got a waggle, right? Unless you're Sergio, and then you waggle for an hour and a half.
Oh, that's my trigger. This is what I've been teaching people, is basically almost like to feel like this back here is kind of getting relaxed.
Okay. So there's the drop, right?
Yes.
Hang on. But if you magnify it too far, you're going to kick them off their foot contact. So you got to be really, really careful. So, but think about that. So you're addressing the ball, you do your waggle, and then what do you do right before you take the club?
I feel like a soft inhale, like a silent inhale kind of deal.
Okay. And then
I'm actually like, my trigger would be to like create some expansion in the left anterior.
Okay. So again, that's what I'm talking about. It's like there's a breath hold and then there's the right. And then they breathe in. To move into that space. So that's the drop.
I'm with you. I got you.
See it?
Yeah.
Yes. Yeah.
So almost like the drop is kind of like the kind of like the letting out of the breath to give space for that inhale.
It has to, because they take a breath in and then they don't breathe out right away.
Right.
And then they release, right? All that muscle tension is released. There's your drop.
In that second release, so you have like the inhale, like top of the breath, maybe like a top of backswing, and then we're kind of on the second exhale, maybe like through impact, or maybe just a little bit before.
Well, okay, so you've got to turn around the top. Okay, there's a turn around the top, right? So we go ER, and then you start to squeeze the ER space closed till you get to, hang on, boss, at the very top of the backswing.
Yes.
Because you have to change direction.
Yes.
Okay, so you're going into the cut.
Yes.
Your backswing. You see it?
I see it. Yeah.
Okay, then you hit the ground up here. You hit the ground. So there's your twist. So you capture the early representation, and then you just keep squeezing it like twisting a towel.
Yes.
You get to the end. There's the stop.
Yeah.
Can't breathe.
Correct.
Re-expand. Start turning this way, and then the same thing happens as you go through impact. Okay, you see it? And then you re-expand towards follow through. right? All of your big motions, all of your big movements are going to be ER representations. Okay.
Yes.
If there's a turnaround, you have to be closing space down, and then you reopen it, and then you squeeze again. There's impact. Then there's your follow through. See it?
I'm with you. I'm with you. Yeah. So when the breath,
You'll hear them. Like anytime, if you're training an athlete and they're doing their sprinting, you can hear when they breathe. You can hear when they like, right? And
yes,
you'll hear like in golf, it's going to be a little bit more subtle, just because the degree of violence is much less, right?
understood.
But
Now,
but you will hear it.
gotcha. So getting back to the trigger idea. So like when I'm creating like the fluid drop, right?
Yep.
Does that ilium have to like go into some IR representation to make that possible?
Okay, so so you're moving towards the early side, you're moving away from the late side. Does that make sense?
Yes.
Okay,
Yeah.
both of those representations are ER bias. Okay. I use the word bias because ER and IR are both there at the same time. Okay. A late representation has more IR represented than the early does, because the early is accumulating IR. The late is pushing IR into the ground, because you have to push IR into the ground. Otherwise, you don't get to the right side in a right-handed golfer.
The late, the IR is dissipating. The early, the IR is increasing.
Yes.
Okay.
But if you look at it this way, right side, left side, okay? It's that. I got to push down more on the left side. I have to let the IR come on the right side. There's the turn. See it?
Yes.
Yeah. So IR's coming this way in the backswing on a right-handed golfer. IR's going that way, away from me. There's the turn. See it?
Gotcha. Makes sense. Makes sense. So then my second question would, this one's a little bit, I don't know. We'll see. So like a lot of like the ground reaction force measurement, like the stuff that we're taught is I'm going to have like a step and then a turn and then a step and then a turn, right? So it's like, please don't throw up when I talk about this, but
it's just walking.
Correct. But like when I walk forwards, it appears to me that the turn, like the foot's in the air as I'm making the turn. So like
You've got momentum, right?
Yes.
Yeah.
So like just to get people the general rhythm of like the step turn idea, like it seems to me like almost in like the fluid might not go the right way, but like if I walk backwards.
Okay, so hang on. So you're the external motion and the internal behavior. All right.
Yeah.
The internal behavior is on a slight delay because it's water.
Yes.
Okay. Do you have a water bag to work out with? You know what I mean?
I need to get one. I don't currently have one.
Okay. Get the clear ones.
Mm-hmm.
Get the clear ones so you can actually see what the water is actually doing. So you'll actually see it vortex, so you can see it spinning. You'll be able to see the delay.
Yes.
That the guts are producing as represented in the water bag. Okay.
Uh-huh.
And that will help you understand what you're asking, because
okay.
because you're seeing the external representation, but you gotta understand that the internal dynamics are on a slight delay because they move second.
Got it.
The way that you'll see it represented in a golf swing is you'll see the body move and then the club follows. Okay.
Yes.
Now at the turnaround at the top, you break out your slow-mo, right? They get to the top, they hit their max P at the top, they start moving in the opposite direction, and then the club bends.
Yes.
The head of the club stays back, doesn't it?
It does.
Where do you think the guts are?
The guts are still up.
The guts are the club head. Okay.
Yes.
Wherever that club head is, that's where the guts are. So when you talk about swing plane, club face position, especially at the top,
Yeah.
you see something that is less than desirable. They're not directing their guts in the right direction because the club head and the guts are doing the exact same thing. So when you see like somebody that's so they drop their swing plane and it gets flat, okay, you got somebody that can't create the delay strategy. So all they're doing is they're orienting themselves in this direction and it flattens the swing plane. Do you see it?
Totally. Yes.
Yeah. So there you go. There's the secret.
Got it.
Okay. It's the club head. Look at the club head. As the club head turns, it stays. You see it on the inside now, don't you?
Yeah.
You get it?
Yep.
Yeah. Yeah. So that's the dirty little secret. So don't tell anybody. I'm trying to keep this.
My lips are sealed.
I'm trying to keep this on the QT. I don't want it mentioned in public because it's if this gets into the wrong hands, who knows what would happen. Good morning. Happy Monday. I have Neuro Coffee in hand and it is perfect. All right. Man, coming off a huge weekend. The intensive 20 was over the weekend. So a little bit in recovery mode today, to be honest with you. It's a lot of output. Some big brains in the purple room over the weekend. Had a blast. So thank you to all of those who attended. You guys were great. Had a great time. Quick housekeeping item. IFAST University members, we have a call today at 1 p.m. Eastern Standard Time. If you're not an IFAST University, go to ifastuniversity.com. Get yourself signed up. Please join us for that call at 1 p.m. All right, digging into today's Q&A, this was Jake. Jake's working with some athletes with anterior orientation of the pelvis, and so we're trying to distinguish between what our expected outcomes would be for a narrow ISA individual and a wide ISA individual. Quick note in regards to what we're referring to as an orientation. So typically what we would have is relative motion between the sacrum and the ilium, and what we have with an anti-orientation is we have everything moving together as a unit. That's why we refer to this as an orientation, because it's very positional. But in this case, when we have an orientation, we don't have access to relative motions. So we need to move people into spaces where they have access to those relative motions, and that's primarily what this discussion is about, because we can't approach it the exact same way, nor can we expect the same outcomes. So thank you, Jake, for asking such a great question. Try to hang in there to the end of the video. There's a little comment in regards to a little bit of phrasing that you'll hear throughout the industry jargon that you want to try to avoid at all costs. So once again, thanks, Jake. Everybody have an outstanding Monday, and I'll see you tomorrow. Jake.
Morning.
What's going on?
So we deal with a lot of athletes, so obviously that comes with a lot of anterior orientations.
I hope so.
Yes. Well, for good and bad.
Yes, exactly.
So what I run into a lot of times is difficulty in restoring relative motions due to the anterior orientations, right? And so what I need to do is be more successful in addressing that.
Yep.
First and foremost, right? So and the distinctions in dealing with it with wides versus narrows. So the way I sort of understand things, it's more of a structural bias for wides who are going to have more compression above sort of that trochanter level, correct? Or no?
Well, so both can end up in an anti-orientation.
Right.
They're just going to do it from a sequential standpoint
Later for a narrow.
Well, it's very easy for a wide ISA because the sacrum is already nutated, right? And so what you see, so there's an angle. So if this is the bottom of L5,
yeah,
and then this is the angle of the sacrum,
right?
I've already got this,
right? Yeah. So right.
So it's a little bit easier for them to capture that orientation.
Yeah.
It's going to go from the pelvis upward, if you will.
Which goes towards my kind of where I'm going with this is so for a wide, would you just sort of need to bias them towards activities that go more towards that counter-nutation inhalation type strategy as a means of starting to alleviate that?
Yes.
All right, that's what I would, and
Okay,
it would,
but here's the thing you got to understand is like they're never going to have a great counter nutation like a narrow will.
Right.
Right. But you still have to slow them down the same way.
Yeah. Okay. And then
it's like, so hang on, let me help. Like expecting a wide ISA individual to sit down into the bottom of a deep squat without some form of compensatory activity it's a rarity.
Right.
And so again, because again, that is the earliest representation of that pelvic orientation. Right. It's not that you won't have wides that can deep squat. It's just like, well, how are they doing it? Right. So you see them like they'll move their feet apart, they'll ER to produce the IR kind of a thing. Right. And so the representation is a deep squat, but again, the orientation is a little bit different. And so you just have to respect the degree of structure, that they're always going to be kind of biased towards that middle representation. Their ER spaces are going to be a little bit smaller. Their IR space will be a little bit bigger. And so when we talk about like slowing them down kind of a thing, it's like, yeah, we're going to try to capture that early representation, but it's not going to look like don't expect like a 70-30 ER to IR ratio, on a wide ISA guy.
Yeah, I try and take those guys generally more back to it towards an earlier middle strategy.
Yeah. So if think about it, if you just use like enough of the earlier representation activities, you usually do actually really, really well with them.
In early activities?
So like an early representation of the foot from the ground up and things like that. It's like they do pretty well. Yeah. The thing you're gonna have to be respectful of is how much space do they have in front of them? Because it's always going to be limited to a degree, right? That's one of the things, because they don't turn. So they don't turn their helical axes like narrows do. So when they're stepping forward, you're going to see a lot more pelvic orientation if they're trying to get the foot straight out in front of them. And so you just got to be careful with that, because what's going to happen is you're going to start to you're going to try to stick them in a space, where like a split stance kind of a thing. It's like they just don't have that space available.
Right. Yeah. I try to more staggers for them than split.
Yeah, exactly. You do. Yeah. You do a little bit more the foot elevation stuff.
You mean like hip approximation sort of stuff?
No, sir. The like 4 foot elevated.
Oh yeah, I got you.
4 foot elevated. Okay.
I didn't know your hands were a foot there. I thought.
I'm sorry. I knew exactly what I meant, Jake. No, it's like, so when you're tipping them up or back, you're actually turning them into spaces that are a little bit more available to them.
Okay. Beautiful.
Yeah, because again, putting them in a grounded position and expecting them to behave like a narrow, it doesn't happen. It doesn't happen, right?
Yeah,
especially with your bigger, stronger guys. It becomes an exercise in futility. You start to see all the IR compensatory strategies and stuff show up because you're just sticking them in a space they don't have. But the recognition of that allows you to guide them into a position where you see a lot less of the compensatory stuff.
And then with narrows, we present with the anterior orientation as a compensatory IR strategy. And the way I'm kind of viewing it at this point is they're doing it because they can't achieve that more of an exhaled IR representation in the pelvis. So that's kind of where you got to try and eventually bring them back towards. And then that should alleviate or get rid of, to an extent, the need for that orientation in the first place. And you can kind of get them back from there.
That is actually the solution. That is correct, sir. It's like the only reason somebody uses a compensation. Okay. And so when we're talking about compensation, let's be really clear about this. What we're doing is we're locking body parts together that would typically have motions between them that can move in opposition. We're locking them together and moving them as one. So when we talk about like the pelvis orienting anteriorly, it's like we've got the innominate, we've got the sacrum and the other innominate that would typically move in relative to one another, slam them together, tip them into the anterior orientation, right? And so you're just trying to reduce that so they move back into the space where those relative motions still exist to whatever degree that you need them. Okay.
Uh,
Cool. Well,
Sweet.
you're on point. You get it.
All right. I kind of had to make sure.
Yeah, but the most difficult thing is to overcome some of the how do you term this? Tradition.
Right. The
Like
whole
everybody
go
should,
after-
like the rules about everybody should be able to. Like if
I got you.
if you hear a statement like that, it's like stick one finger in your ear, listen to it out of one ear, but don't listen to it with both, because you got to take it with a grain of salt. Right.
That was my question. Like the differences between how you're going
Right.
to address
Right.
it between wides and narrows. It's not going to be the same way. So
It's not going to be the same. It's like, and keep in mind that we're always talking about the extremes for the purposes of understanding. Like take the narrowest of narrows that you got, the widest of wides that you got, and then just watch them. Good morning. Happy Tuesday. I have Neuro Coffee in hand, and it is perfect. All right. Still catching up from the intensive 20. So we're going to dig straight into today's Q&A. This is with Alex. Alex has been on the call in a while, and we were in a sort of a knee heavy situation, and Alex didn't let us down in that regard. He had two neat presentations. The commonality between the two is recognizing the fact that in both situations, we had a knee result. So we have other influences that are producing these outcomes. One, he had a patellar tendinopathy with an associated patella alta. So that's an upward movement of the patella, and Alex caught onto that one right away. He sort of had a great grasp as to why that presentation would be affecting the knee as it does. And then we went a little bit deeper on the second presentation because we had to look at archetype, we had to look at compensatory strategies, we had to look at the position of the center of gravity to determine why this other knee result would have occurred. But we laid it out, I think, very, very effectively. And so I think it's going to help a lot of people as far as the understanding as to why you would see some of these issues arise. In many cases, it's not going to be a knee, it might be something else, but the premise is the same. We want to start looking at these relationships. The foundational archetypes are going to give you the point A, we're measuring point B, and then we just reverse engineer and close the gap. So thank you, Alex. Great questions. Great to see you again. And everybody have an outstanding Tuesday. I'll see you tomorrow. Long time.
I know. Been a little bit. I've had some lifts at this time, so it's coming up to finals week, so I get a little time back now.
You know why I do these at 6 a.m. Eastern?
Why?
Because I only want the people that care.
I thought I'd continue with the trend of some of the knee questions you're getting today.
Oh, awesome. Okay.
What
What episode last week? See, I don't know if you saw last week. It was a foot call.
I did see that, yeah. So it goes in waves, right?
It does. We come back around to the knee. Go ahead.
So I actually have two different representations. First one's kind of quick. I just thought it was interesting. So both are female basketball players. One of them's just been getting some bilateral kind of patellar tendinopathy symptoms, pretty common. But talking to the athletic trainer, he said that she was like diagnosed previously with patella alta, or like patella's like riding up, a little higher than normal.
Yes, sir.
And I thought that was kind of interesting. The way I interpret that, and kind of based on how she presents too, is kind of concentric orientation of like the VL and rec fem pulling everything out into ER. Okay.
Yes, sir. Okay. Two diagnoses that I love. Patella alta. Do you know what the opposing diagnosis is?
I don't know what you would call it, but I'm guessing
patella baja.
Okay.
Alta means up, baja means down. The reason I like this is because Cabo San Lucas is one of my favorite vacation spots, and it's on the Baja of California, which is the lower hook. It's that lower piece of California that's Mexico, not the United States. And so that's always how I've remembered it since I was a student. It's like Baja. Oh, it's the lower part. So Baja's down, Alta is up. Squinting patellae look like they're looking at each other, right? So yeah, but what all you're looking at is you're looking at the orientations of the femur and the tibia, and then you're looking at the muscle orientation that's associated with it. So wherever the patella goes kind of tells you what you're looking at from a structural standpoint. So you're absolutely on point with the Baja, because the Baja is just going to get pulled upward. Well, how do you pull a patella up? Okay. Right. Well, you got to put it under tension.
Mhm.
Okay. So now the question mark is, so where is the actual symptom?
Anterior knee, like right dead in the middle.
Okay. If you poke on them, where's it hurt?
Like right below the patella.
So like patellar tendon, inferior pole of the patella, right?
Hmm.
So where's it getting choked?
Right there. No.
Yeah. Yeah.
Oh, yeah.
Absolutely. Absolutely. Yeah. So pull on the tendon, twist it a little bit, choke the towel. So if I got a towel full of water and I twist the towel, what happens to the water?
Squeezes out.
Yeah. How does a tendon get nutrition?
Through the fluid, through the water.
Yeah. So
Gotcha.
if ain't no water, guess what? You're choking, right?
Makes sense.
Yeah. Yeah.
Awesome. That's what kind of what I was thinking. But yeah, I just wanted to kind of get your take on it.
Yeah.
And I'm guessing my other one isn't much different. It probably has some similarities, but I've shown this girl and then like one of the intensive calls before. She's post-op ACL. She's probably about 10 months now post-op. And we keep kind of running into this cycle where every time we start to introduce higher volumes of impact again, she gets this kind of shooting pain up her like medial knee, almost like kind of medial shin. And
On the plateau?
like
Can you show me?
probably like right about here.
Okay, I got you. Uh-huh.
And like I know this girl can't, so she's like far over to the right, and I know she can't acquire the IR position, so she can't acquire the force producing position.
Right.
So like I think I know what the problem is, but I'm kind of having some trouble transitioning.
You tell. Help me.
What's that?
You tell. Like, what's going on?
Well, she can't acquire the IR position, so she can't propagate the forces
Okay. So
up to the pelvis.
this is the left knee.
Yes.
Okay. All right. So let's think about this for a sec. Is she swayed forward a little bit on that left side?
Yeah.
Okay. So if she swayed forward, okay. She's got a flat DR.
Yes. She's up here.
Yeah. Okay, cool. Yeah. And so it looks like she's hiding $100 bill. Right?
Yeah.
Yeah. Okay. All right. Perfect. So let's think about this for a sec. So you've got an ER representation proximally.
Mhm.
She is going to create an IR. Okay. So she's going to have a little bit of the outward curve to the femur.
Yes. Yep.
Okay. Where's the bowstring? So the femur is going to give you the representation of the bow, right? But she's got a bowstring that's going to go straight down from the pelvis towards the foot to create to keep the IR inside of her base of support, right? She's got to produce it somewhere. Okay, so there's going to be muscle activity that's going to create the bowstring. Is there? So let me back up. If she swayed forward a little bit, do you think she's got a rectus strategy going on?
Oh, absolutely. And if
Okay.
you look in her toe touch, it's just
Got it. Oh, so she's got the little house on her back?
Yeah.
Perfect. Okay. So that's a bowstring.
Mhm.
Like rectus abs is a bowstring. It's going to pull it's trying to pull the sternum and the pubis into a straight line, because if I do that, she can't fall forward outside of her base of support. So it's going to try to hold her down and inside. Okay. But in the lower extremity, I've got this outward curve of the femur that's creating the ER representation, which means that I'm bending it this way, which means that there has to be a bowstring that's bending it, helping to bend it down.
Mhm.
Think about where that bowstring is. It's on the medial knee. Okay. It's on the medial knee. Do I have a muscle that looks like a straight line from the medial knee that goes up to the sternum?
Is this gracilis?
Might be gracilis, dude.
Gotcha.
It's attached right to that medial plateau, right?
Hmm.
And so if the bowstring is tight enough, okay, then it's going to reduce the amount of movement that you have available in that proximal aspect of the tibia. So whatever position the tibia is in, it's going to stay there, right? Okay. Now, because you've got an ER representation most likely in that proximal tibia, it's going to start to turn inward. You're probably looking at where that transition is taking place, where she feels this pressure on the inside of the knee. It's probably going to be a little bit distal to the attachment of gracilis, because again, it's going to be right below that part. And so you're going to get this, you're going to start to see the differential like right through there. And so she puts a downward force on. And so that is where she's putting the IR. Like it's landing like right there.
Right below that, like gracilis attachment.
It'll be just distal to it.
Okay.
Where she feels the pressure. Get it? So there's a quick test. You lay hands, right?
Do mobs.
Okay, so if you think about like the prone or a half prone, capture that medial knee position, right? She'll start to superimpose some IR on that. You'll probably get a reduction in the gracilis activity. Okay.
So I've been using half prone since you did that demo with Drew. She definitely struggles to capture the medial knee in that. So if I would have been, and I try and prop her upper body up a little bit more.
Yeah, but so do this though. So left side, right side.
Yep.
Do that.
Like
build it up on the left side.
Like left knee is up on like a bench or a box.
Like if you had her on the floor.
Yep.
And you put her in a symmetrical prone, boom, just tip it a little bit.
Like toss some Airx pads under there or something.
Exactly. Yeah. Gotcha. Try that, see if you can capture it that way.
Okay.
Yeah.
Perfect.
But do you see the mechanism here?
Oh yeah, and it's exactly what you're talking about. Like toe touch is like she's cranking straight down.
Right, but so think about this. You get the prone gives you an advantage in regards to the rectus strategies, right? Okay. So you might have to go like just like a prone on elbows. Start. You could put her in side lying and do the ISA activity, right? To start to create the turn. And then go prone. If you can reduce the rectus strategy, guess what else is going to get reduced? Gracilis is going to follow. Okay.
That makes sense.
Okay.
Awesome. Thank you.
Welcome, sir. That was good.